Welcome, everyone. It's 7:30 Central Time, 8:30 Eastern Time, and 5:30 on the Pacific Coast. So we have a large group of friends here tonight. Several more will join us later, and I think we'll be around 1,000 people before this webinar has been fully visualized. So we're really happy you're here. I know there's a big interest in new techniques and methods. ASPN has a policy of trying to develop best practices. And what that is, we get a group of experts together and we look at all the evidence that's produced in the literature by our colleagues and friends. And then we look at the gaps in literature and we look at clinical experiences and the early adoption of these procedures and techniques and methods. And we try to come up with what will help you keep your patients safer and get better efficacy in each of these methods. So tonight we've put together an amazing panel of some of our great friends, but also some of the most influential and leading people in the field who really have a great deal of experience with this technique and method. And we're going to talk about this new way to treat this type of pain that's often elusive in the past. So Dawood, do you want to introduce our topic?
Yeah, absolutely. Thanks, Tim, and thanks for everyone that's joining us tonight. I can say that, we've done quite a few of these webinars over the last few years, and this one's really piqued a lot of interest based on the registration list that we've seen. So it looks like it's going to be one of our most highly attended ones in a long time. So we know that the interest in this therapy is there. I think, what Dr. Deere has done over the last, I guess wouldn't even say last, most of his career is really, he's put together a lot of these best practice guidelines. Everyone knows about the PAC guidelines and the NAC guidelines. When we formed ASPN a few years ago, one of the things that we really wanted to do was to continue that and kind of put the power of ASPN behind a lot of these guidelines. And we've done a number of those over the last, 2 years or so. And this is our latest one. Again, this is a best practice guideline for, treating vertebrogenic pain with basovertebral nerve ablation. And just kind of some background on when ASPN puts together these guidelines. This really is kind of things that may potentially benefit certain people in industry, but industry is hands off on these types of things. They really have no insight into what we're going to publish. They have no influence into what our findings are going to be. So even though I can say there's some companies that have a direct interest in this, and they were probably pretty happy that they were doing it. They never know what we're going to do, and we have a very pretty prescriptive way that we go about this, the way we rate the evidence that we've taken across all sorts of therapies. Dr. Greider and Dr. El Said have helped us kind of form a really strict grading criteria where we use United States Preventive Task Force grading criteria to look at the evidence, and we create kind of evidence grades. But this guideline has went beyond just looking at the evidence. We've also looked at, compiling all the evidence, looking at, patient selection. We tackled, an algorithmic approach to this and tips and tricks and pearls to those that want to incorporate this. If you look at the authors of the best practice guidelines, I think, it's really diverse, not only in specialties. We had, neurosurgery and surgeons involved in this, interventional radiology, physiatry, anesthesiology, primary care. But we also had, people that were from diverse areas in their, practice, very established folks and people very young. We had quite a number of residents and fellows that actually helped in developing these guidelines. So I thought that was really cool and interesting to see, to put this together. Next slide. Thank you to Relievant. Relievant has given us the ability to provide this webinar tonight for everyone across the country and world at no cost. So this is me and Tim. These are kind of what we talked about, and we can jump into the next slide here. And we'll go ahead. I'll just kind of kick it off with, kind of one of the key statements of the guideline summary. The BVN ablation we felt is grounded in solid foundation of both preclinical and clinical evidence. And ASPN really identified the need for these formal evidence-based guidelines for proper identification and selection of patients for BVN ablation. Many people that are going to be tuning in today have done BVN ablation, but a lot of people will be like, what is this? They're going to start completely from scratch. And we think that, these guidelines are really going to be a one-stop shop for people that really just want to learn everything there is to it. You really can pick up these guidelines and really go from there. Tim, any points?
Yeah, just a comment. I think, I'm an early adopter of most procedures once I feel they're safe and efficacious, but I was a skeptic of this procedure initially, and I went back and looked at the preclinical work and then looked at the clinical evidence as it builds. So I do think that when this webinar ends tonight, I think you'll have a better understanding of both the theory and the clinical application. And it made me actually believe it's certainly a theme we might want to offer to our patients with this type of pain syndrome. So I think that process is important for best practices, but it's also important for you personally to get comfortable with something, to make sure you understand why you're doing it, whom you're doing it in, and what are the chances of success. And I think the reason we wrote this guideline is we feel that this technique now has reached that criteria. So Dalwood, let's go to our first panel.
Yeah, so let's introduce our two first panelists. So we're going to kind of go through these panels and follow along and kind of give you the Cliff Notes version of the guidelines. The guidelines is about a 20-page document when you include all our references, and it's widely available, and we'll share the link. It's on open access for everyone to look at and print out, or just watch. You can look it on your smartphone or whatever. So it's there for everyone to kind of reference. It did hit the press, last week, so the timing on this is perfect for us to talk about this. So our two first panelists really don't need much of an introduction. Dr. Douglas Beald is a world-renowned interventional radiologist that practices at Oklahoma, involved in pretty much everything that's new and innovative in the field. And Dr. Kiran Patel is essentially the Dr. Doug Beald version, or Doug is kind of the Kiran version in Oklahoma, I should say. She's the East Coast version, a powerhouse on the East Coast in New York City, who's has her hands in just about every new innovation and intervention in our field. So they're going to take us through a little bit about the pathophysiology of vertebrogenic pain and modic changes. So I'll start with you, Doug. As a radiologist by training, I remember when I was first kind of introduced to this, and unbeknownst to me, I'd have patients when I was a resident, when I was going through the MRI with them before I present to my attending, they'd always point to this long straight line in the middle of the vertebrae, and they'd go, "Oh my gosh, doctor, what is this? It's all the way up and down my spine." And as a resident, I was like, I really don't know what that is, but I think it's normal. So can you tell people, what is the basovertebral nerve, and where does it come from, and what's kind of the innervation of this?
You bet. Well, that's something that we didn't really understand until we started looking at the pathophysiology of pain that's transmitted from the end plates. So the basovertebral nerve comes in, it dives down from the sinusovertebral nerve. It comes directly from the dorsal root ganglion. That dives down after the sinusovertebral nerve passes the posterior portion of the end plate. Then it gives rise, branches off into the basovertebral nerve. The basovertebral nerve continues with the basovertebral vascular plexus, and then arborizes when it's about 40% of the way forward from the back. It starts to arborize and then gives branches to the disc, and these have been tested to contain substance P, so they do transmit pain.
That's a helpful description. I think the slide is very nice as well. Just a follow-up question, Dr. Patel. I think one of the things I get asked all the time by both residents, fellows, nurse practitioners, and colleagues, we talk about the modic changes we see in these cases. And a lot of people, they've heard the term, they don't really know what that means. Can you give us a very brief kind of this thought process on how to identify that?
Yeah, so there are three types of modic changes. There's type 1, type 2, and type 3. And so, on T1 weighted images, we're going to see the type 2 images that are hypointense. And then on the T2 weighted images, they're going to appear hyperintense. And these are classified as subacute and chronic changes. And this is the bulk of patients who, for this particular therapy, who we are targeting. Type 3 modic changes really refers to that kind of bony, sclerotic appearance, which is a much more chronic, much more developed stage of modic changes.
That's helpful. I think the T1, T2 weighted images are going to be really important for people to look at, because I think looking at one view is not going to be enough in these cases. Dalwood?
Yeah, I got a follow-up question for Kiran too on these modic changes. At least, in some circles, it can be controversial whether, these modic 1, say, for instance, modic 1 changes, are they symptomatic? You'll hear it in some circles, they say, if you get MRIs on asymptomatic people, they will have, some motic changes. What's your kind of opinion on, motic changes, and are they symptomatic, and how do you kind of tease that out when you see patients, when you see these MRIs?
Yeah, I mean, you really have to correlate that with the clinical symptoms. These patients who would be symptomatic are patients who have pain that's worse with bending, with sitting, with reaching, with holding. I always say it's, certain movements like putting a baby into a crib, taking the garbage out, lifting the heavy garbage out and taking it out into the street, those kinds of things. So you really want to correlate it with the patient's symptoms. I teach fellows all the time, and we've seen motic changes, and we've seen some motic changes that aren't symptomatic. But on the other hand, there are patients who give a history that seems very motic-y, as I often say. Like I said, this patient, they may not have motic changes right now, but the pain that they're describing, they're in their 20s or 30s, and we know that motic changes, we see degenerative changes in the disc more so in the 20s and 30s. When we start to see degenerative changes in the vertebral bodies, that's more in the 4th and the 5th decades of life. And I have these patients, who have kind of grown with me in my practice, and I'm saying, like, their history is always consistent with this, and we've never seen the motic changes. We order a new MRI, and lo and behold, we start to see those changes. And I think that's largely because we think that what is going on is that, there are cytokines, there are neuroinflammatory markers that are released from the disc, in degenerative states that then lead to a neuroproliferative state in the end plates themselves and a sensitization of these nerve fibers. And then what we also see is that it's almost like a cycle, so that we have a increased diffusion between the vertebral body and the disc. And so it's kind of this perpetuating cycle. And so that's why you may find a patient who has a history with pain that's worse with sitting, bending, flexion, reaching, weight bearing, driving, all of these things. And then later on, you'll see that they actually develop the end plate changes.
That's very helpful, Doug. Let me ask you to think of that answer. I really appreciate it. That was a very helpful thing. Doug, here's another question I think I had today with my group. We were discussing this procedure. As you add it into your group, the first question I'm going to get from a lot of people is, number one, you see on this MRI slide, there's obviously some changes at that one level, and you have some, some narrowing and a lot of other issues. What if you have two levels that look abnormal, short of a discogram, which a lot of our younger colleagues have never done, because I know you've been 5 years, or currently discography has not been a part of practice. Short of a discogram, what are your thoughts on identifying which pathological state is actually the target for us when we start doing these procedures? How can we tell 4 versus 4 or 5 when it's axial back pain? It's not, we can't look at them, right?
So as Dr. Patel mentioned, we have 3 different kinds. I think it was fluid, fat, and bone. 1, 2, and 3, those are the easiest types to remember. And one of the things that Mike Modik described these things back in '88, and then they went through, yes, this is a marker for pain, we need to look for it. Then they kind of went out of favor and back and forth. And the reason this was so controversial is somebody that was asymptomatic can have motic changes, and that was fine. It's similar to arthritis. Not all motic changes hurt. But then when they do hurt, they did notice that, and we put a couple of pieces into the literature recently, that motic type 1 changes, the fluid changes, are more predictably painful than motic type 2. So Anthony Giuffrida, one of the other panelists, we just published a paper with intradiscal injections identifying this, and that's essentially what we came up with, was that motic type 1 changes really was a stronger marker. And if you have motic 1 and motic 2, you would pick the patient that has motic 1 that's more likely to be painful. If you have motic 1 or 2 changes and you have back pain, the likelihood ratio is about a 3.4 that motic changes, those motic changes, are what's giving rise to your back pain. So if you flip it the other way around, yes, asymptomatic patients can have motic changes, but if you do have motic changes in back pain, there's about a 70% chance that those motic changes are the result of your back pain. So we do so in terms of motic types. We do so in terms also of severity. There's a really nice article that came out recently in the Gray Journal, and this is Journal of Radiology, that measures the degree of motic change. And if it's less than 50% or greater than 50%, if it meets the halfway mark, emanating from the end plate, if it meets the halfway mark up the vertebral body, then it's more likely to be painful. So the bigger the modic change, the more likely it is to be painful. So those two things are pretty reliably able to be employed to determine, even if you have multiple levels of modic changes apart from the discogram, just from imaging alone.
No, that's very helpful, Dawood.
Well, that's a fantastic kind of primer to this, and we look forward to having you guys come back on the next panels here. So thanks, guys, for getting us setting the tone perfect.
Yeah, what a great start. I think that start's phenomenal and lets us understand what we're looking for. And now let's think about, once we understand that, is there evidence that actually doing something with that nerve based on those changes would actually be helpful? So we welcome our next two panelists, Dr. Mehta, Dr. Nandu. Welcome.
Hey guys, thanks for having us.
Good to see you both. So I guess we'll just kind of start. This section kind of explains itself, but I'll start with Pankaj. So, can you kind of walk us through kind of some of the earlier studies on BVN ablation and how that kind of spoke to you clinically?
Yeah, first of all, welcome everybody, and thanks for having me. So I think, the first time when I was introduced to this was, I think, the very first or the last West Virginia meeting, which was in Miami, and I was on a panel for this, and I specifically asked Dawood not to ask me a question on the evidence, and guess which was the first question he asked? What is the evidence behind this therapy? So that kind of spark my interest in kind of reading about this. But honestly, I think if you kind of look at the spectrum of how the evidence was built up from the right get-go, even the first kind of the pilot clinical study, where they saw the patients who underwent the BVN ablation on the 3rd month follow-up, which is usually the kind of the first primary outcome when we measure the results were statistically significant, maintained for 12 months. And the evidence kind of built up on that. There was a prospective single-arm cohort study which showed a drop in the VAS score by, of almost 4.3 points, leading further to the level 1 IDE study, the SMART trial. And when you kind of follow the patients up to 24 months, you start seeing that there's this statistically significant, clinically relevant drop in the ODI. And we all know that when we talk about back pain, when we talk about spine induced back pain, if you want to call it, ODI really becomes it's kind of the hallmark outcome measure. And then everything is built on that, right? The psychometrics, the VAS scores, everything is built around that disability scores. And you see here about 54% drop of the ODI maintained up till 24 months. There was a significant drop in the VAS score. But I think a couple of things came kind of very evident when you kind of specifically read the 24-month follow-up in the paper, which is actually on the website. You guys can, anybody on the audience here can kind of download that paper. You see here that when you follow these patients at 24 months, a vast majority of those people had a greater than 10-point improvement in their ODI, and almost half or more than half of them had a 20-point decrease in the ODI. But not only that, and I'll let Ramo kind of carry on later, but when you kind of compare these patients to 5 years, and we saw this with some of the therapies in our space, that sort of the gold standard which is becoming is follow up to 60 months. Is this therapy sustainable? Is the drop in ODI, is the drop in the pain scores and improvement in functionality maintained up to 60 months? And clearly what was intriguing was, especially when I kind of adopted this at a larger scale in my practice, Dawood, was that I saw that the drop in the VAS scores, the reductions 4.3 point was maintained up to 60 months. ODI reduction was maintained, but what was intriguing was also almost 1/3 of the patients were completely pain-free. And what that tells me is that when you have this kind of age range, disc pathology leading to vertebrogenic pain, what Doug Beal just spoke about, literally 1/3 of those patients kind of are pain-free, which clearly makes sense why their ODI had improved drastically.
No, that's great. That's a great, I think, overview of the evidence and gives us a great summary. Ramo, I have a more practical clinical question I think you can help us with. Let's say a 55-year-old woman comes into the office with an L4-5 disc that has the type of modic change we just discussed a moment ago, and she has pain when she bends over to pick up her bag or do things at home. So the question she asks you is, based on the current literature, the evidence, what's my odds of a good outcome with this procedure? What would be your thoughts and answers to that question?
Yeah, that's a great question, Tim. And what I tell patients in that exact same situation is that based on our SMART data, which Pankaj just went over, that there's about a 70 to 75% chance that you are going to see at least a 50% reduction in your pain, just based on that data alone. And even for the patients who don't achieve that 50% mark that we're very accustomed to in our studies, a number of other patients get anywhere from that 10 to 50% range. And for this cohort of patients, where in this study, the average length of time they had chronic low back pain was about 7 years, this is a really, really hard problem to deal with. And so for even those patients who get a 30% reduction in pain for us who are accustomed to 50% or more, that's actually okay for some of these patients, because I get patients, and I know all of you guys get patients who have had chronic low back pain for 20 years, and they're not a surgical candidate, and they try everything else and nothing else works, or epidurals work for a day or a week or maybe a month, but they're just not getting that duration of therapy that they seek. They're going to still see some benefit. And the worst case scenario I tell patients is it may not work, but a majority of patients are going to see some degree of relief, and 70% are going to see at least a 50% reduction in their pain. And as Pankaj said, almost 30% see complete resolution.
Wonderful, great answer, Dawood.
Yeah, that's a really good answer. I have a question kind of for both of you. So when you talk about, the Fishgren paper, which was the RCT, we talk about, designing studies. I think they, to the, the industries kind of, to give them kudos, and maybe the FDA kind of put this on their plate. This is a pretty high quality study. You talk about randomized RCT with a sham arm, and actually a true sham procedure was done here. One of the criticisms that came out of the initial data set was that even though the patients on the pain level, they did well, the sham arm, they all actually did well too, and there may have not been a really great statistical significance in pain relief. There was in disability. What's your guys' thoughts on, sham arm and this study design for patients with chronic low back pain, and why is this evidence, still very powerful? I'll give it to Pankaj first and let Ramo answer it as well.
Well, I think one of the things is that I think the statistics can be kind of twisted and churned in different ways. There's a couple of ways. When I kind of read that paper, it was either I could have looked at it from that point of view, or I could have looked at the patients which were being followed up and were basically 1/3 pain free. So I don't know how to kind of like sort of criticize the paper, but I think from my point of view, the evidence was pretty clear.
Yeah, this is a great question, and I think there are 3 ways to look at it. Number one, we've got to examine the placebo effect, and I think that's a really important thing we need to all accept in all of our studies. And there really is a call to action to have more sham-controlled trials in our space, and I think it's important that we do that. I think we need to watch the criticism about doing that and seeing that, the therapy group and the sham group are relatively close. There is a placebo effect in a lot of the things we do. And if we don't study that compared to sham, we're not going to know the true benefit. And I think the true benefit is something we see over time. Number 2, from a physiologic standpoint, maybe some of those patients had facetogenic pain, medial branch pain, and those trocars that were the shams got those nerves. So maybe there was some relief there. And then last but not least, just doing a procedure itself, you do create acute pain, and it changes their perception of their chronic pain situation. So a lot of factors are at play. So I too have the same criticism as you guys, but I think we need that degree of honesty in our studies, and I'd like to see that with a number of the procedures we do, have a sham control to really understand what those differences are.
I'm going to close this with asking you both one question, and it's about yourself. Let's assume you both have discogenic disease because you've been out playing pickleball. And Ramo, you get to pick between, this is 3 years from now. And I'm assuming we're going to have more evidence in both of the things I want to ask you about. What would you rather have, this technique, the BVN ablation, or would you rather have a biologic in your disc? You get to choose one or the other. What would be your choice?
Pankaj, do you want to start? You want me to start?
Yeah, Ramo, you start. Yeah.
All right, perfect. So assuming this, I've had more than 6 months, Modic, all the same criteria, and it's really kind of a flip of the coin, I would choose this based on the long-term evidence.
Great. Pankaj, any disagreement there?
No, I would do the same thing. I think there's really no evidence in biologics I see. And then just based on the science, which we've just presented, and the pathophysiology, I think it's a no-brainer.
Great. Well, wonderful panel. Thank you both. Great thoughts. We'll see you both a little later.
Thanks, gentlemen.
Our next panel looks at really making the diagnosis and what I asked a little bit about earlier, but more on a clinical level. We have Dr. Durkin and Dr. Patel joining us to talk about the diagnostic approach and patient selection, which we all know is everything. Dawood?
Yeah, so thanks for joining us again. We'll just jump right into it. So Dr. Durkin, you're probably one of the most experienced basovertebral nerve ablation performers in the U.S. Really kind of adopted this therapy and kind of run with it. So when you see this, axial back pain, it's like pretty much every patient I see, 80 or 90% of them. What's your kind of diagnostic approach to these patients when you kind of select them out for basovertebral nerve ablation versus all the other stuff that you can offer for axial back pain?
Thanks, Dawood. It really comes down to the history, and in everything in medicine, it's really the history, and the history. Little physical exam, and then confirm something with an MRI or X-ray or CT scan. So it comes down to the story. Patient comes in with back pain, and I ask them, and this is something that I've really changed in my practice over the last 4 years, is really teasing out whether it's anterior column pain versus middle column pain versus posterior column pain. When I started in this field 17 years ago, it was if you came in with axial back pain, it was most of the time we would address the facet joint. If you had a big whopping disc and no leg pain, or leg pain that went away after an epidural and you still had back pain, then we would start talking about discogenic things and IDET and those things that really are not available anymore for various reasons. And that was really the Moby Dick of our field for a long time, was treating axial back pain that wasn't facetogenic and didn't have any, and wasn't stenotic type of pain, back pain. So it really comes down to the story. So the first thing I do when I see a patient is I ask them if they have back pain when they're sitting, going from sitting to standing, tying their shoes in the morning, driving for a long time, leaning over the kitchen sink to do the dishes or cook or pick up their grandkids or their kids. And once I start hearing yeses to those things, and you can see in patients the light bulb flashes when you hit them with what their story's about. Then we go to the MRI and we look for not just modic changes, but really in-plate degenerative changes. And if those things correspond, then I start thinking about Intercept.
Brian, I think you just hit a home run helping explain this. I think that was a great summary and probably the best I've heard. Karen, I'm going to ask you a little bit more challenging question. And that is, you have someone who comes in, when they bend over their sink, it hurts. When they lift something and bend forward, it hurts. Their disc shows the MRI changes we're looking for. But when they play golf or use the weed eater or extend their back, it also hurts a great deal. Where do you start? I mean, they have facetogenic pain, as Brian mentioned, but they also have findings that would suggest Intercept might be the thing to do. How do you know where to start?
Yeah, so I think a lot of it also becomes to patient education. And as Dr. Durkin just mentioned, when people used to simplify kind of axial back pain as all comers, but now we kind of realize that there's pathology that exists in the anterior elements, the middle elements, and the posterior elements. And so when I'm educating patients, I often say it's, I use an analogy similar to the foundation of a house. There's stuff in the front of the house, the middle of the house, and the back of the house. Right. And so we talk about, the foundation, and so that how, you could have facetogenic changes, but you could also have vertebrogenic changes, and they're going to affect you at different time points and with different movements and different activities. And so it's about educating the patients and kind of teasing out which bothers them the most. Currently, many of us are using, we're trying to obtain greater access to this therapy for our patients. And so, we may identify that they are symptomatic from anterior elements, from vertebrogenic changes, based on flexion, driving, sitting, bending, holding, something heavy, bending with something heavy. And so we want to treat them for that, but we may not be able to do it right away. But at the same time, we may diagnose that they have also, changes consistent with pathogenic pain. And so in the meantime, in the interim, we may go ahead and start to treat the back of the house because it's more readily available. And so that's often a conversation that I have, even on a first visit with some patients, kind of teasing out which symptoms bother them, what bothers them the most, and then what bothers them with specific activities, and then explaining to them the different therapies and how we can go about obtaining them, in terms of accessing care.
Great thoughts. Darwin?
So Brian, we tried to attack a couple of these things. I think the nice thing about the patient selection for this can be pretty straightforward, but we all know that patients will have certain issues where they can't maybe they can't have an MRI, whether they have a pacemaker or a non-MRI compatible spinal cord stimulator, etc. What's kind of the workaround for those types of patients when you can't get that?
A great question. And we see these patients more and more, and I don't understand why people are still putting in pacemakers that you can't get an MRI with, but that's a different discussion. But I see patients, and if you can see, sometimes you can actually see what would be motor changes on an MR better on a CT scan. And I'm actually trying to pull up a picture because I was just in a conversation this week with another pain doc in our state who is looking for patients that would benefit from BVN ablation that can only get a CT scan. And I'm trying to find a picture here, and I can in a second. And I think a picture is worth 1,000 words. And here's a patient here. Let's see. I know you can see that, but you can see those end plates are all broken up, right? At that L5, L4, 5, and S1 level. That's a patient that I would, if they had the symptoms of anterior column pain and they couldn't get an MR and the CT was only available, those are great patients to offer this therapy to.
Oh, great. I love that. That was a great picture, actually. I can't believe we could see it on the phone like that so well. Karen, Dr. Patel, here's the last question for you in this segment, and that is, if let's say this is you with the same issues, I know what Brian's answer would be because I've seen his Instagram post, but let's say you had the same problems that we just pointed out. That was your CT, and you're offered a discectomy by your local orthopedic spine surgeon versus this technique. What would you opt for?
Well, I think that's a common presentation, and I think a little bit more diagnostic work has to be done. In terms of the pathophysiology, we know that degenerative disc changes is what we ultimately think leads to the vertebrogenic changes. So I think it depends on kind of how the MRI has progressed. I think it kind of depends on, what other therapies patients tried and what's been somewhat effective or suggestive. So I think it's kind of a simplistic question, but we need to do more workup and kind of figure out what does that patient exactly look like? But it is a very common situation that we see with many of our patients. Is it the disc?
Absolutely. It's become the choice we make, right? For our patients, we help them make that decision. Brian, you get the last word on that. What would you decide?
Wait, I got one question though. I want to ask the last question on this one.
Right,
Brian, okay, you ask me first. I got one though.
What was the question again?
Darwin, you get to ask.
How's your back feeling, Brian?
Yeah, so I for about 3 days I was the most famous person in America who had intrastep procedure done. So I'm about 120 days out from my procedure. And then Karen did Carson Daly's BVN ablation 3 days later. I'm back to normal. I'm working out. I can run for the first time in forever. It's been life-changing to me. So I'm like the Cy Sperling for this procedure. Not only am I a provider of it, I'm also a customer, and it's been a great life-changing event for me. It's been the best back pain-free summer I've had in 20 years.
I assume that's the Hair Club for Man president. Is that who that is? Okay.
That is.
So let me ask you a question, because so I want everyone to understand one thing and know what, Dr. Patel does an amazing job of the procedure. I've seen her social media, the post and all, but I want to ask you this question, Brian. This is my last question for this panel. And that is, how much does it hurt? I saw you with your fingers up when you're having it done. Is it a painful procedure to have done? As a patient?
At all. So I got a little bit of ketamine, a little fentanyl, a little Versed, and a little propofol. I actually had committed to giving a lecture on the future of the treatment of interventional or the treatment of back pain that afternoon. So I actually did the procedure. I had my my trusty nurse practitioner on standby to fill in for me if it was too much, and Kristen Klein was ready to do it, but I was able to do it, and I gave a nice lecture on the procedure the same day that I had the procedure. So not a big deal for me. Now I'm not like everybody. You know, I'm a little more motivated, I think, than the average person. And some people that I've done the procedure on have been sore for a week. But most people, I think, tolerate this procedure very well, and it's very little impact on their for post-op recovery for patients.
Perfect. Dr. Patel, Mac or general for most people?
Mac.
Okay, thank you.
Yeah.
Great job, guys. Thank you so much.
Awesome. Thank you.
All right, on to our next panel. What are the other options? And we're going to talk about that a little bit with our next panelist. So welcome, Anthony.
Thank you, guys. Thanks for having me.
Doug's a little far behind you. Maybe the bandwidth in Oakland. There he is. So both put you guys both on this one because we know you guys not only do basivertebral nerve ablation, but you do a lot of other procedures for patients that maybe present similarly. We all know that a lot of patients kind of present with some pretty generic kind of symptom, back pain, axial back pain. What's your kind of thought, Anthony, on, you know, say you got a patient that, and Tim kind of asked a similar question to Ram and Pankaj earlier, where you're thinking, you know, an intradiscal therapy could be an option, maybe BVN ablation. And say you're a believer in both of those, how would you kind of figure out who's an intradiscal therapy candidate and who's BVN ablation?
Yeah, I think that decision's made for me sometimes right now. So I see a ton of motor change patients. I actually, like Doug said, we just published this paper on motor changes and interdiscal steroid injections. The reason I say the decision's made for me is a lot of times it takes time to get this covered by insurance. You know, we put them in the portal, and I just want to leave this patient there hanging. So I will do an interdiscal steroid injection to give them some relief in the meantime. As for biologics, the question was asked earlier, I think we need more data. Would I try them? For sure. I think there's plenty of data that shows it's not going to be harmful to the disc. It's not going to be harmful to the end plate. We can try them. The data isn't there for me enough to tell a patient, though, you know, like I can with BVN ablation. I can't say 75% of patients are getting 50% relief out to 5 years. I just don't have that backing. And I'm a data-driven guy, right? I want to be able to tell my patients the truth with what I have and what our science has right now. So I am all for interdiscal therapies. I actually tell most of my patients stem cell therapies into the disc is the holy grail of spine. And if we figure that out, I think we can fix most of spine or prevent a lot of spine injuries. I think it starts there. So I'm open for one, doing them, and two, for studying them further. I'm actually in 2 research projects right now to study stem cells into the disc. So I know Doug is too, and it's very exciting where the field's going. But overall, when it comes down to it, when I have a patient with motic changes and axial back pain, to follow the data right now is BVN ablation. And one last thing I want to say, I think it's a great question because 5 years ago, our answer was nothing, right? Maybe surgery. We used to fuse these things just to make it stop moving. So the fact that now we have BVN ablation and then maybe even other things 5 years from now is pretty impressive for our field.
So let me follow it up to Doug. Anthony, I loved your answer. That was very good. Doug, let me ask you something that goes back to our careers. You know, we used to do IDET. I thought it worked pretty well in some patients. We did that in our practice. We did percutaneous cystectomy with the drill, and I really thought that worked pretty well in our practice. We saw our surgeons do black disc surgeries quite often after a discogram showed abnormalities. That works sometimes. We saw some disasters and led to a lot of SCS. So if I'm an insurance company medical director and ask you, how do we know these procedures we're talking about tonight, particularly this procedure, what's your thoughts on how we can prove this will not be something like that that goes away? How can we make this valid long-term treatment for this type of pain?
So I think what we have to do, Tim, is we have to just parlay on what we've done so far. We've got randomized cohort trials with sham. We've got one with comparison to non-surgical management. We have prospective single-arm cohort trials. We extrapolated the Fishgren trial, and we've taken long-term data, So we have data out to 6.4 years now. Now we're starting to get the 7-year plus data from the SMART trial. And so it's durable. We can make a medical economics argument. We can make an efficacy argument. And going back to what Anthony just said, you know, we have data that says from our intradiscal cellular therapy trials that have about 70% pain and functional improvement. And on basivertebral nerve ablation, you know, I tell my patients it's a rule of 75. We have about a 75% response rate. On the average, if you're a responder, your pain goes down 75%, and it appears to be durable or permanent. And this is pretty good when compared especially to black disc surgery, because if you do black disc surgery, you've got about a 50-50 response percent-wise. And then again, even if it is successful, you know, based on registry data that we have, about 1 in 5 patients will have to have repeat surgery within 4 years. So that doesn't look very good in terms of outcome. And, you know, the registry data says the outcome for a good, excellent surgical outcome for that is about 33%. And that's much less than what we're collecting for both cellular therapy and BVN therapy. I just have one additional thing I wanted to add, and I agree with everything Anthony just said. One of the concepts I brought up just in the previous session was the thing about modic grade. So we have modic changes. We type them, type 1 through 3, then we have modic grade. And if we have modic grade just going up to the end plate, that's grade A. 25% of the way from bottom to top is B, and more than 50% once you get past the 50-yard line, that's grade C. And there's the recent paper that just came out that said the grading may be more important than even the type in determining whether or not that's painful. And the grade C, for example, is more associated with modic changes type 1. And so whenever we look to do these therapies, I think everything that points to type 1 and grade C, that's a really good BVN ablation candidate. And those that are for modified Fearman's grade 3 through 6, so moderate amount of disc degeneration with less than a grade C, that appears to be a good intradiscal cellular therapy candidate.
Great. Dawood?
So, you know, this panel is alternative treatments, but I just kind of pivot a little bit. You guys have both done a ton of these. If you guys had a wish list for maybe an alternative way to access or ablate the BVN, I'm gonna ask both of you kind of what would be on that wish list. I mean, do you think the current system is the best way and it cannot be improved upon? Anthony, I'll ask you that first, and Doug, I'll let you tackle it too.
Okay.
I mean, I'm the one thing I wish is it would be a little easier to get down the pedicle on younger patients with really hard bone. I think, you know, there's hand drills that can be used, but just from working with my surgeons, I know there's some really advanced techniques in the surgical field to get through hard bone. Could that be developed into some kind of trocar where it almost is like an ultrasonic scalpel technique to go down? I think that's my biggest issue is getting down the hard bone, and then that curve can be tough. I mean, we've all been there where it just doesn't curve as much as we would like. I think, you know, there's newer systems coming out where the curve could be easier, because you really want to get that nerve. If you don't curve posterior enough and you're too anterior, you'll miss that nerve and it won't even do the procedure. So those are the two issues I'll have with the procedure that could be a little easier in the future.
Doug?
So I'll jump in here. Yeah. So one of the things I hear most often about this is it's moderately difficult, and to agree with that. So I've been doing this for a long time, and I've accessed the vertebral body thousands of times in my career, and it is moderately difficult in terms of targeting. The new tools that are available just recently will probably make the targeting easier. They're more robust, and you're able to steer that into the target area right before the arborization, right at the trunk of the tree, about 40% of the way from back to front, and really hit that. I think to be able to improve upon that yet. So number one, the new tool set will probably improve targeting quite a bit and make this less than at least moderately difficult. I think what the real holy grail would be, because of the innervation pattern, if we were able to get the singuvertebral nerve as it came off the dorsal root ganglion right before it gave rise to the branch of the basivertebral nerve, and doing so maybe under endoscopy, maybe a protected radiofrequency, insulated radiofrequency ablation, maybe mechanical ablation if you could identify appropriate targets for those nerves and be able to denervate that right when that came off. You'd get a twofer and be able to denervate both those nociceptive substance P carrying nerves. And that could be a very nice way to do that. There's a Korean article that just came out about a technique on how to do that. And I think to further that, to investigate that, additionally to figure out exactly what technique is effective in doing it may be a better way to ablate.
No, both of you gave phenomenal answers. Anthony, we have 30 seconds left. You get the last question. I thought both those answers were amazing. So you guys should invent those things the next month or two before most of our viewers start to do this procedure. Here's your question. There's a lot of venture capitalists that watch these webinars we put on. A lot of them come to our meeting at Aspen. We have a lot of strategics that are on here tonight and will be coming to Aspen as well. So for vertebrogenic back pain, you get to recommend an investment in one therapy that's available out there currently. You can say anything you want. Where would you put your investment right now based on where you think we're going to be in 5 years?
I think the safe bet with the data is BVN ablation. I think the riskier bet and maybe the bigger payout in the long term would be stem cells, but I don't know who you're investing with that. I think stem cells is a riskier bet for everything in the body for medically, but I'm looking to invest in stem cells. Let's put it that way.
You know, we gave you one answer. You gave me two. I think that's a good political answer. I like that. So we're going to take the first one. All right.
Be risky. I'll say that. You're young, be risky. If you're older, be safe.
All right. I like it. Very good.
Great job, guys.
Thank you both. Next panel.
I bet.
All right. So we've talked about a lot of things. Everyone that knows me knows one of my goals is always create an algorithm, which, you know, tells us where we go first and as we advance. Dawood?
Yeah, so I think, Ramo and Pankaj have both done a great job of developing algorithms within their own practice. And then they were really critical in us developing this guideline and this algorithm, which I think is probably going to be the most important part that comes out of our guidelines, so people can really figure out, who is the right patient. So Ramo, can you kind of walk us through kind of a high-level view of this algorithm? We can kind of flip that slide up too to help you.
Yeah, absolutely. So I think the reason that both Pankaj and I, and you guys obviously, are super interested in algorithms is that, as we know, there are so many different pain generators of the spine, and it's really challenging and complex to understand when you have several minutes with a patient to figure out, is this person, and what treatment do I have that matches that diagnosis? So our goal is to impart to all of you in the audience, what is the algorithm to help you identify these patients so that you can get to this therapy that's really well evidence-based. So this is the algorithm that we created with Dr. Khatri I got to work with. And it's really straightforward. It's really going after the labeling as it's indicated for BVN ablation, which is 6 months of chronic low back pain, failing conservative measures. And then we divide it into anterior, middle, or posterior column pain. And the way we do that is by asking a patient to lean forward versus lean backwards. And if the patient has more pain with leaning forward, that suggests it's the anterior column. So if you think about the biomechanics of the spine, the fulcrum of the spine is really about the posterior 20 to 30% of the vertebral column. So if you imagine flexing forward, the front of the spine is taking the force or the pressure, and that, if it causes pain, therefore means the pain generator is somewhere anterior to that fulcrum, meaning it's either the vertebral body or the disc. If you rule out vertebral compression fracture, which obviously you can by imaging, then you go on to identify whether they have modic changes 1 or 2 or not. If they have modic type 1 or 2 and they follow through, they are a candidate for basivertebral nerve radiofrequency ablation. If it's modic type 3 or there's no modic, you may consider some of the things that Dr. Jafrida and Dr. Beal were talking about, which is intradiscal therapeutics, whether biologic or whatever else. So that's the whole algorithm. It's fairly straightforward. I think this is not only a great thing just for you to incorporate in your mind, but to print out, post in your clinic for your APPs, even your MAs, and other people in your group so they can help identify these patients as well.
Great job. Tim?
No, so I think that summarizes that quite well. So, Pankaj, you and I were together recently. Well, we're together all the time, it seems, but which is a pleasure and an honor to teach with you. But, you really talked a little bit about the algorithm with your team, with your APPs and your practice. And so a lot of times as we evolve in these practices, you know, you see the patient's a new patient, and then you may do some procedures and you may not see them again for a while. So what's the algorithm look like clinically? What are you doing to evolve? The first day you meet someone, you examine them like Ramo just said, you think it could be vertebrogenic pain, but then they also have facet disease, other issues going on. How do you recommend to your team, when you teach your team to be part of your decision-making process, how to get here? And I know it's a complicated question, but I think it's gonna be important for our viewers and people who are in clinical practice.
Yeah, I know, Tim. I think actually it's a very important question, and I think in today's era of so many therapies, like Ramo said, especially within the APP community and how we work, we're seeing an attrition of this sort of therapy fatigue is the word I use. Like, you know, there's like always 10 therapies, and it comes down to like, okay, well, out of sight, out of mind. And I think really what Ramo pointed out is exactly what I do is the very first visit you decide, am I going to go to the anterior column or I'm going to go to the posterior column? We also forget a lot of times that more than 65% of the force of the spinal column is carried by the disc, and the workforce is the anterior column. And it all starts from the disc. And the disc is the first epicenter of the degeneration. And if truly that carries the majority of the force of biomechanical force of the spinal column, then I think that should be addressed first. And I know there's a lot of symptoms, you know, patients are like, I don't know, doc, you know, my back hurts, my leg hurts, my sciatica hurts. And then, you know, somehow back pain became synonymous with facet pain. So we all kind of got focused on facet pain. I think that if we have to have a clear triage algorithm that, okay, the patient has an anterior column problem, posterior column problem, and we decide there's no right or wrong. You know, you can start from facets, you can do the posterior column treatment, but we always have to remember that the anterior column is where it started off from. And if the anterior column, if we decide, okay, we're going to work on the anterior column for the next X number of weeks, then the first question is there a discogenic component, or is there pain on flexion, like Ramo said, a lot of people said tying your shoelaces, and, you know, Kieran said carrying the garbage back on the street. We don't do that in Texas, but, and then a lot of other things. So, and if the answer is yes, that you have a pain on flexion, we know that the anterior column is stressed or strained. And then really the question is there a bioradiographic marker associated with it? And if the answer is yes to these three things, then I think it's a no-brainer. The only FDA-approved treatment right now is what we're discussing. And then we can go to the posterior column. I think the big problem, Tim, to your question, is like the fatigue between the APPs is like, well, okay, well, let's do an epidural, and then, you know, come back into a facet and patient, oh, I'm still hurting. Okay, well, what's hurting? And then you suddenly see spinal stenosis. And I think it is important to lay down those pit stops of the DDD cascade, and then it's just kind of go from one end to the other. And I think that's has been a very been a success algorithm in my practice.
Yeah, that's great. Great answer. Ramo, question for you. So this algorithm, you know, is pretty simple. I think we wanted to make it simple. I think it can be simple and, you know, implemented effectively. But sometimes we have patients that don't look like this. They're not that simple. So how do you kind of incorporate patients in your algorithm that say have had previous spine surgery, have a spinal cord stimulator, have an intrathecal pump? How do you kind of incorporate them into this algorithm, or are they just not candidates?
That's a great question. So I'll be super frank with you guys. About 2% of patients follow this algorithm really smoothly. So yeah, check, and we get to, you know, BVN ablation or whatever else. But about 50% of patients come with a mixed picture. And like you said, they have other therapies, or, you know, there's been a lot of difficulty through our entire group figuring out what the pain generators are. And so in those situations, sometimes you have to lay out to the patients, frankly, I don't know what's going on here. You have pain with flexion and extension. And so now I have to figure out which are your pain generators and then rank order them. So I explain to patients, you know, the way I think of injections is really as diagnostic tests. And a lot of patients come to me and they think, I get an injection, I feel great, and I don't see you again. And I have to basically change the way they think about that, because that's what they've been used to from other providers in the community. Get an epidural and I'm good, and thank you for that. But I have to tell them I'm using it as a test, whether I use steroid or not. I'm using it to figure out if that's the source of your pain. If it works 50% or more, we go this direction. If it doesn't, we go this direction. And I lay that down and I write it down so they start to understand, because if it doesn't work, what does that patient do? They leave if you don't explain what step B or step C or step D is. And so laying that all out, I just had a patient today where there were 4 potential pain generators, and I have to lay out 4 different injections I might do depending on the results. and you don't want to go too far because it gets really complicated. But if you take the time to do that, you can start to pick out these really complex patients who might have had a failing pump or a failing simulator that in fact have had this underlying pain generator the entire time. And you come in and you figure it out and you do this, they can make a huge difference. And to get to a point that Dr. Beal always talks about, even though the functional anesthetic discogram is not a requirement, it can be very helpful in these situations. So if you do see those modic changes and you are wondering, gee, is that level involved in this, this might be a great situation to do an FAD. And in our community, we have to have patients pay cash because there's really no reimbursement from any payer. I know in other parts of the country it is reimbursed, so great. But if you have to bring that up, don't be afraid. You can say to a patient, look, it's not covered by your insurance, it's out of pocket. If you're willing to do it, you can consider it. And of course, that's not easy with every patient, but certainly something to offer in case they really want to know and you really want to know if that is a source of pain.
I think that's a great answer. And, I think discography is one of those things that, certainly I think may see a resurgence here because of issues like this. And I think we're going to see more young people learn how to do discography. I was telling folks today, L5S1 is a little difficult, but everything else is pretty easy. So I think we can teach that quite well. The 30-second question, Pankaj, it's going to be a difficult one for you. So this I'm saving the hardest for last. So we're going to be presenting at NAS a large 270 patient multi-center prospective study of SCS and non-surgical back patients, which I know many of you were involved in. And I can't talk about the data tonight, but let's just assume it's over 80% response rate at 6 months and 1 year and maybe out further, and you have a patient like this, in your practice, Pankaj, and you only get 30 seconds, so it's going to be a complicated answer. Where do you go? Do you go to SCS if the data is level 1 and high level data? And I'll let you know how that turns out when we go to NAS, or do you go to this procedure? What's your first choice and why?
I think it's pretty simple in my mind. I think when we use the word back pain, and me and Ramo have spent countless nights at the bar discussing what do we mean by back pain? How do we define back pain? I mean, is it nociceptive, is it neuropathic, or is it a blended pain? And is it same thing, anterior column, posterior column? I think while that particular data may show SCS is a great therapy for intractable low back pain, I want to know what is that back pain. I haven't looked at what the definition of back pain. Here, I have a target. I know I have triaged the column of the spine, plus I know the target. I have narrowed down the epicenter of that back pain, so I can define that back pain. And because I've been able to define the epicenter, the treatment is pretty clear to me. Now, it's possible that maybe the answer, Tim, is in future is a hybrid therapy. I don't know. But I think that'll be the new set of evidence patterns we'll be seeing in future in our space, which will be hybrid treatments.
No, great answer. I think that ends this panel, but I think the answer might be both. You might do this and treat the discogenic vertebrogenic pain, and then you might go back and treat the rest with SCS. So it could be both. It's just got to be that algorithmic step. Great job, both of you. I thought that was a great. Thank you. Our last panel, let's go. Last panel tonight's coming up now, I do believe.
Last one to take us home.
We see Anthony and Brian talking about clinical pearls of the technique. So, Anthony, a lot of people don't do kyphoplasty in their practice, and they've never done kyphoplasty. Looking at this method, it's very similar. What would be your advice on getting trained? Is this a hard thing to be trained for? Do you need to be mentored on several procedures? What's your advice on training?
So 2 things to say there. The training team that's out there right now at Relievant, they're the only ones doing basal nerve ablation, is excellent. They have a very good training program. You should feel very comfortable doing BVN ablation, getting down the pedicle after this procedure. And I think the one thing, even people have done a lot of kyphoplasties, is accessing S1. I think that was always the biggest daunting thing before you get into your first S1. But really, as you do more and more of them, you get better at it. And I think one thing is, even as myself and Dr. Durka, we might have done, I think the 2 of us have done probably the most in the country. I'm far second. But is that we keep getting better as we go. And I think that's shown in the data. As the data keeps showing, that really nice graph you guys had earlier, the level keeps coming down. So I think that's one thing we need to harp on, is when you're first starting out, take your time, get down the pedicle perfectly how you need to be, and really make sure that curves in. Because with kyphoplasty, we're just trying to get into the vertebral body. With basal nerve ablation, we have to get in at the right spot. So take your time. The other thing I like to say, and this is my 2-minute soapbox I always say when I'm on any of these, is we need to start being surgeons. We need to do preoperative planning with all these new procedures we have out there. And what I do for preoperative planning is I measure my angle that I'm going to be at and the distance I'm going to be from the spinous process on the MRI or CT scan beforehand. That gives me a general entry point of where I'll be to get that trocar to go from lateral to medial as I traverse down the pedicle. So those are a few little pearls I have. The preoperative planning's huge, but reach out to us too. Me and Brian, you know, we're always available to anyone out there that wants to talk about how to do this procedure, how to get to X1, how to do the preoperative planning. And so is the team at Relievant. They're always available to help you out. They're the only company right now that does this, so that's why I'm mentioning them, but there's a lot of support out there.
No, great answer, Darwin.
Yeah, Brian. So, you know, Anthony mentioned S1 being a challenging level to access, and you've done, you know, several hundreds of these cases. Can you walk us through why is S1 so difficult? I think you might be on mute.
There we go. Yeah, so the shape of the S1 is makes it more difficult to get to the midline because it's not as deep of a vertebral body, and the angles of the pedicle are quite wide, and you have the iliac crest to deal with. So those three things can make it difficult. I've seen Doug Beal post up where he comes from a lateral view, which is pretty cool. I haven't done that yet, but there are ways. There's multiple ways to skin a cat. But yeah, when I started doing this 4 years ago, I hadn't done a vertebral augmentation in about 10 years, just through politics and my situation. And again, I didn't really pursue a vertebral augmentation, so I really hadn't had much experience accessing a pedicle. But I was one of the first in the Northeast to get trained, and I've done a ton of these things. 10 cases, and I was ready to go down the pedicle. Not a big deal to do. With anybody that knows their fluoroscopic guided procedures, you can do it. If you can do a DRG, you can do a BVN.
Well, they're a little different. I think you'd be a little bit more, gentle with DRG than this, but that's another issue altogether. So here's my question for both of you. We started doing all these techniques, in the last few years, and what I found was, and I've been asked many times now, I get X-rays sent to me for my opinion. We never realized how many L5s look like L6, and is it S1 or is it L5 or is it L? What's going on there? Is it L4? There's sacralization and lumbaralization. How do you avoid, and we don't have much time left, so I just want to make sure I get the pearls from both of you. How do we avoid doing the wrong level? What's your advice?
I can take that. I mean, what I do is I kind of already mentioned it, preoperative planning. First of all, another thing that we have to say is you have to read all of your own imaging. Don't go off a report. I think that can get you in trouble sometimes. If you see a modic change, it says modic change at L5 S1. Even if it says sacralization, you get into the OR and boom, all of a sudden you have no clue where you are. So what I do is I have my imaging up in my procedure suite, my OR, while I'm doing the procedure. And that second you go lateral, I want it to look exactly like it looks at the MRI up on the screen that's right there. So really set yourself up for success. Me and my fellow go over every case beforehand. He has the pictures, I have the pictures, we have it on the wall, just to make sure you don't get the wrong level. Definitely something you don't want to do.
Right. But Brian, what if you count from the bottom up and T12 ends up being with no rib? I mean, these are the types of questions I get asked all the time, right? You count from the bottom up, if you count that direction, the bottom space is 5-1, and then you get to the top and there's no rib at L1. So then was that the right space? These are common questions I'm hearing.
About 8% of patients have these anomalous lumbar spines, right? So this is not uncommon. And like Anthony said, the most important thing to do is preoperatively plan your approach and get your imaging in line. And if you can have it in your OR, that's great. I can't remember people's names, but I can remember their MRIs. Yeah. And if I look at an MRI, I can tell you, which level is which. It's just a curse, I guess. So yeah, very important to preoperatively look at your imaging. Like Anthony said, don't look at reports. I haven't looked at. I'll look at a report to make sure that somebody's mentioned it after I've diagnosed the situation and have indicated the patient for the procedure.
Dawood, last question of the night.
Yeah, so Anthony, typically based on the data and the previous experience, the ablations were around 15 minutes per vertebral body level. Now, I think there has been some interest and some real world use with potentially doing shorter ablation times and still having a successful outcome. I'll ask both of you guys a question about the outcomes, but can you tell us when and where potentially you could maybe go for a shorter ablation time and kind of what those times have been in your practice besides the standard 15 minutes that we've been doing for all these years?
Yeah, I mean, we talk about how it's hard to get down the pedicle or moderately difficult. I think what Doug said to get down the pedicle with this. You still always got it done within the 15 minutes. The lag time on this procedure was the 15-minute burn time. And actually, as of August 1st, I think it was, there is if you're in the target zone, we call it, then you're allowed to do it for 7 minutes. There's plenty of data that shows if you're in the target zone, you only have to burn for 7 minutes, which has really cut my procedure down time-wise, actually to the point where I've even been done with a burn before I'm into the next level sometimes. And that makes sense to me. If we're not right on target, if you have weird anatomy, scoliosis, you may want to still burn for longer, 15 minutes, and that's at the physician's discretion. But you can burn for a shorter time, which is 7 minutes, which has really helped out the OR time.
Brian, what do you think about this targeted approach? And I assume you've kind of been able to do this on a handful of patients already. Have you seen any change in outcomes?
Yeah, it's been great. So when I started doing the 7-minute lesion back in April, we did a pilot. And we've actually captured data post 6-week MRs on these patients to look at the lesion. We've done 12 patients so far. We're going to present that at the NICEP meeting in November, I believe. But you can't, the naked eye can't tell the difference between the size of the lesion between the 7-minute lesion and the 15-minute lesion, and outcomes have been great. So once you get good at this, and it's not going to take a ton of cases to get good at it, if you have good hands, you're going to be able to get posterior in towards the trunk, as we say. And a 7-minute lesion will let you. And I've done the case skin to skin in 18 minutes so far. That's my fastest case so far for 2-level BVN ablation.
And I will say to our colleagues out there that when you first start out this procedure, it may take you quite a bit longer. So take your time. Dr. Durkin's probably the world expert in the procedure. So I think that's important. Look forward to seeing you both in both New York SIP as well as in Aspen and Vegas. And Dawood, you want to talk about the next things coming up here before we close?
Yeah, first of all, great job, gentlemen. Thanks again for giving us your expert opinion. That's just a wealth of knowledge for us to all have access to. It's really great. So, we got quite a few other things coming up here. So, Dr. Lubenow, program director at Rush, will be leading the fellows webinar going over kind of fluoroscopic anatomy for interventional pain procedures. It's just a wonderful, opportunity for those fellows that are just kind of starting their fellowships. And we invite pretty much anyone, residents, APPs, anyone to kind of join this webinar if they so please. Next slide. Innovation Summit, don't miss this, December 9th through 10th, we're going to have, again, a really large lab offering as we did last year, followed by a data reveal where we'll be going through kind of some of the newest and really groundbreaking evidence in the field. So don't miss that. It'll be the Bellagio, Las Vegas, December 9th through 10th. Hope we can see you all out there. There's the QR code. Next slide. And then the Super Bowl of debates. We're kind of, hoping that we'll be celebrating, my Kansas City Chiefs again, kind of making it to that point. They're starting out pretty good here. So 2023, January 10, Super Bowl of debates. We got a pretty cool lineup set for that.
Yeah, it's gonna be a great lineup. We're gonna be celebrating Tom Brady's next Super Bowl win. It's gonna be amazing. And I think we're gonna be raising some money for St. Jude Children's Hospital and have some special guests on that night to talk a little bit about that. And I think the debates will be probably really intense. We'll probably have people like Kieran Patel and Ken Chapman and Brian Durkin on there, and we'll see some intensity going, and it'll be great discussions.
That'll be great. Final thoughts there, Tim?
No, I think remember to put on your calendar the 5th annual conference, July, Fontainebleau. We kind of unfortunately outgrew Lowe's Hotel. We have too many people now, which is a wonderful problem to have. The dates on that, Dawood?
Yeah, July 23. I don't know it right off the top of my head.
July 14th through the 18th.
Sounds
Lincoln, there, tell us the dates.
Yeah, I believe it's there. Yeah, we cut that off there, but the date has been set, so it's there on the website, so you can mark it off and book your hotels and all that stuff here fairly shortly. We're really looking forward to. We're moving into the Fontainebleau. It's a great location. We're still on Miami Beach, so we'll never leave Miami Beach. I don't think so. We'll just continue to up Miami Beach a little bit from the lows, just because we need more room. So.
Yeah, that'll be great.
Thanks to Relievant for sponsoring this webinar. And again, I think, we think that all these therapies really do need to undergo criticism and critical review and have published evidence and literature and webinars like this, so everyone can kind of decide if and whether it's relevant in your particular practice. I know personally, I did a case of this afternoon in a patient that I think is going to do quite well. So I've kind of made the leap over the last year, and I've been very happy with the outcomes and results I've been getting.
No, I think again, I want to say that we really appreciate innovation, and the companies that are innovating out there and the ethical way of doing great research makes it easy for us to set best practice guidelines. So I really encourage those companies that are out there. Certainly if you can reinvest some of that money into doing level 1 data, even level 2 and level 3 data initially, I think it's going to be helpful to really bring to the patient access with insurers. So please continue that. We appreciate Relievant's efforts in that field, and we look forward to future studies, both sponsored and unsponsored independent studies to show the efficacy of this technique. Thanks for joining us tonight. It's been a great discussion. Hope to see you soon.